TANA's AHEC staff for permitting both the State Bar Healthcare and Better Law sections to co-present this morning's Friday medical conference and combined CLE, continuing legal education, for the attorneys in the audience. As usual, the medical staff present this morning will receive 1 CME credit for your attendance. However, the attorneys will enjoy 4 credits from the State Bar, which includes 1 ethics credit this morning, which of course we're all clamoring to get before our reporting period ends this month. We have 4 segments to cover this morning. Each will run approximately an hour in length. It will include a 5 to 10 minute Q&A session at the end of each hour, so keep that in mind as we progress through the morning. So then we'll take about a 5-minute break between each segment. We have a lot of information to cover this morning, so we're going to run pretty quickly through it. Restrooms for the conference center are right at the end of this hall on your right. So our first speaker this morning is Dr. Christopher Jons. He is our St. Patrick Hospital Inpatient Palliative Care Medical Director, graduate of Dartmouth Medical School, board certified in pediatrics. Dr. Jons was first at St. Pat's in our pediatric hospitalist program, and then he left us. He went off to do a 1-year fellowship in palliative care, and we are overjoyed to have welcomed Dr. Jons back to our ministry here at St. Patrick Hospital. So, Dr. Jons, if you'll come up and get us started.
Before I even begin, I've come undone. I apologize. Thank you, Rick. Is this volume okay?
Sounds good.
All right. I'm happy to be here to talk about medicine and law and what's the interface here. We're going to focus on one area about advanced care planning to hopefully help our legal colleagues develop some tools in conversing with their clients, and hopefully help our medical colleagues develop some tools in warding off the lawyers. The hardest part is going to be not making many lawyer jokes. That's going to be the most challenging part for us. So if I fail, then you know at least I've tried. I'd like to begin with a case presentation. In the format of a true medical conference, often these rounds begin with a case presentation about a specific case that illustrates some of the issues we'll be talking about. Then I'll give a little brief overview of what the landscape looks like at end of life in America and how things have changed, as a way of illustrating some of the challenges that the tools that we'll talk about help to address. And we'll talk the few tools we'll talk about whose goals are clear to help align the process of dying and end of life with the patient's wishes for their care. That's the goal of these tools. And we'll spend some time talking about those, about living wills, about power of attorney for healthcare, and about POLST, or physician orders for life-sustaining treatment. And then we'll finish with a case presentation as well. And we'll have time for questions, of course. So, to begin, I'll tell you about a patient who no identifying details are here. And I've changed a few specific details just to keep it anonymous. But a 52-year-old male who was generally healthy aside from his history of significant alcoholism. He was drunk one night and he fell down the stairs and suffered severe injuries. Significant traumatic brain injury, as well as a high cervical spine contusion with vertebral fracture. So for those of you who haven't had one of these or don't know about it, he broke his neck really high up. Generally how it works is if you damage up here, your spinal cord loses the ability to do everything below that. So if you damage it here, you might not get to walk. If you damage it here, you might not get to do anything at all. So he survived and spent the next 4+ weeks unresponsive, totally unresponsive, intubated in the ICU, without any spontaneous movements, on full life support. Eventually, if someone is intubated long enough, meaning if there's a breathing tube in their throat long enough, you can't leave it in there forever, so they transition to a tracheostomy, which is a permanent breathing tube that goes in the neck. So then a patient can be hooked up to a ventilator or a breathing machine permanently or indefinitely. He obviously wasn't able to eat if he was unresponsive, so he had a gastric tube surgically implanted in his stomach so he could get tube feedings through that. There had been some family meetings before this time, and they all sort of went like this. His daughter said he'd never want to live like this. I should say, he was estranged from his wife. He was still married, but they were estranged. And she was not involved in the decision-making process. She yielded to the daughter to make final decisions. His daughter said he'd never want to live like this. His sibling said he's a fighter. He's not ready to give up. The daughter, or the siblings and the family got along well enough that they wanted consensus. They didn't want to be fighting about all this stuff. So the let's wait and see attitude is what triumphed. There had been no real prior conversations about specific wishes. This was a guy who he kept to himself. His history of alcoholism and some history of mental illness certainly played a role in that. But also the culture of the family was not one that really talked about a lot of these issues, which is the culture of most families, honestly. And there were certainly no advance directives or any formal instructions for what to do in a situation like this. So after 6 to 8 weeks, his traumatic brain injury improved slightly, so he was becoming more and more alert. And at the same time, the extent of his spinal cord injury was becoming more apparent. He would be permanently quadriplegic. So he has a little bit of movement of his shoulders, a little bit of movement of one of his arms, but no functional movements would be possible. And so he will require 24-hour care, 7 days a week, indefinitely, meaning for the rest of his life, however long that is. Because of his social situation, that would certainly have to be in a facility somewhere. And that wouldn't be in Missoula, because Missoula doesn't have, rural communities don't have settings that can handle patients like this. So his mental status was slowly improving little by little, but he's still dramatically impaired. So family meetings went like this. At this point, everyone sort of recognized, gosh, he probably wouldn't want to live like this, knowing that he's never going to be outside of a facility for the rest of his life, that he's always going to have 24-hour nursing care. The biggest issue for his family were the dignity questions, meaning bowel and bladder care, for example. He will always need assistance with that. That was kind of a non-starter for them. So the family felt that he would have preferred withdrawal of ventilatory support, so coming off the breathing machine and be allowed to die a natural death, knowing that he wouldn't want to live like that. But his mental status at this point was improving somewhat, enough that he could participate in some conversations, but not really enough for fully informed consent. However, what he was saying was not, I want to die, it was, I want to live. So he sits in the hospital awaiting placement now at a permanent ventilator or a C-spine injury facility. No one feels that this is a great outcome right now. Hopefully it'll turn into a good outcome as his mental status improves, and he can either give us more information about what could happen or make more concrete decisions or arrive at consensus. But it's a tough case and illustrates some of these concepts. So let's talk a little bit about how people are changing. Now, this is all stuff we hear in the popular culture over and over, so I won't belabor it too much. But Americans are getting older. We're living longer. Great. Yay. Serious illnesses, chronic serious illnesses are improving. Here's just one. Here's the prevalence of Alzheimer's disease. You can see starting in 1900, it was hardly there at all. And then we have what looks like almost an exponential growth curve, or at least certainly not linear. It's rising in all age groups significantly. So people are getting older, and they're getting more of the diseases of elderly people. And we're spending tons more money, as we all know. An unsustainable amount of money on healthcare. I don't think that's a value. I don't think that's a loaded statement. I kind of want to stay apolitical, but we only have so much money. Let's just say that. Another graph showing the growth in Medicare expenditures over the last 35 years. Most of the, well, not a significant amount of the care that we spend are in the last few years of a patient's life. Now here's a map. I just like to show this because Montana actually does pretty well in this regard, in the sense that we are below the median in terms of dollars spent, Medicare dollars spent in the last few years of life for chronically ill patients. So we do pretty well. Now, I don't know what that means to do pretty well. It's the kind of thing we can feel good about without really knowing what the factors are that going into it. But I'm all for that. Sure, let's feel good about it. But you can see that some of the high spending states like California, some in the South, and especially urban Northeast, thousands and thousands of dollars is the average amount spent for chronically ill patients in the last few years of life. The most obvious correlation that we know about is the if you build it, they will come phenomenon. That on the coastal areas where there are more, and in Texas and Florida, where there are more medical centers and more to do, then people spend more money on it. That's the obvious correlation. You can imagine how many hospitals there are in New York, all competing for one another, and if you build it, they actually do, they really come. This is sort of a tough one to see, but more money, tons of money says that, tons of data says that more money spent does not equal necessarily more quality care. Now, quality is really hard to define, so I won't dive into that. Some people say quality is extending life. Some people say quality is not getting bed sores. Some people say quality is not dying from your heart attack. We can all sort of disagree on exactly what quality healthcare looks like. So we won't parse that. But it is, this is basically showing a relationship that on the left here is the quality ranking for states. And on the bottom here is Medicare spending. And this is one of these great studies that shows that the more you spend, quality outcomes can actually drop. So again, we can argue with this a lot because we won't go into specifically what they measure. But the point is that more money spent by no means equals better care. And I'm sure we've all heard this at various times. US, the top red line is us, and the other lines are everyone else. And this is the amount of money that we spend on healthcare per capita, as well as a percent of GDP. So as you can see, as a percent of GDP, we are in the high teens at this point, and in the almost high thousands of dollars, single-digit thousands of dollars per capita annually. So we live longer, more diseases, spending a lot more money. We haven't cured death yet. We're working on it. Well, not me, but the smarter people are. We're still going to die. So here's how it used to be. In the early 1900s, Average life expectancy would have been around 50 years. This is not the time of the saber-toothed tiger, so it's not, you weren't going to get eaten by a mountain lion. But one of the big reasons that life expectancy was so low is because childhood mortality was really high because of infections. Maternal mortality was really high because of all the complications that can go wrong in childbirth. But infections is certainly the reason that that average life expectancy was much lower at this point. So before antibiotics, people just tended to die fast. They'd get pneumonia, they'd die, or they'd get any of the vaccine, now what we call vaccine preventable diseases, viruses, bacterial infections, and they would die. So medicine was really limited in what it could actually do. Certainly physicians were held in high esteem in society, but medicine was much more focused on caring and comfort than on curing or prolonging life, because there were so few tools. And the sick, of course, tended to be cared for at home. It wasn't until the middle of this century, really, that hospitals really started to be a place where people went a lot. And the reason is because there wasn't anything to do at the hospital. But medicine's gotten good, so we now have science in medicine and technology and all sorts of tools for communication. And what these have portended is a marked shift in the values and the focus of our society. I mean, I don't think it's a stretch to say that we are somewhat of a death-denying society. I think some of this is unique to the American ideal of independence, autonomy, productivity. And I don't think it's inflammatory to say that our culture tends to perhaps devalue aging, devalues family to some degree, and the interdependent caring or intergenerational caring. Medical therapies now really let us fight aggressively against almost all diseases. There are very few diseases now that we really can't do anything to help treat. The clear examples would be some of the neurodegenerative diseases like Lou Gehrig's disease, where we really got nothing, unfortunately. But for most other diseases, I mean, this is amazing. I mean, just imagining how many thousands and thousands of things can go wrong with the human body. And for most of them, we can do something. And because there's stuff we can do, we certainly do it, and this is great. Obviously, public health things played a huge role. Having good sewage systems this century has limited, really almost reduced to zero, serious outbreaks of diarrheal illnesses. And antibiotics, of course, is a big one. So life expectancy is now, of course, not in the 50s, and it's climbing into the mid to high 70s at this point. Of course, it varies dramatically within certain populations, and there are populations, certainly in western Montana here, where life expectancy is dramatically decreased. But death is not so easy to accept anymore. And I think we can all agree that there's somewhat of a sense of failure if a patient is not saved. So let's briefly look at patterns of decline and death. What I hope for, I think we all hope for, and when I talk to patients, what I hear the most when we talk about how people imagine dying, they say, I'd like to go to sleep and not wake up. That sounds amazing, right? I want to be ready for it to happen, but that means I'm not suffering, it's not drawn out. I just go to sleep. That sounds great. So that's kind of like a sudden death sort of situation, which is great in theory. Doesn't really happen is how it turns out. I mean, it happens, and I shouldn't say it doesn't happen. People die of heart attacks all the time, but in the big picture, it's less than 10% of people who will die suddenly from an unexpected cause like this. So this is the first heart attack in a patient who maybe knows they have some heart disease but doesn't really know. the huge heart attack and died, or the accident. No one wants to die of an accident, but you can, if we graph health status and time, I'm switching over here now. Good health status, dead. All right, happens fast. Great. Another, so that's less than 10% of the time. So that means 90% of the time it's not so clear, it's not so clean. Here's a graph which maybe something like being diagnosed with metastatic cancer. So a terrible thing to have happen, but we kind of know what it'll look like. So feeling good and then get a diagnosis of some terrible disease, and it's a pretty steady, predictable decline to death. It's not always so smooth, of course, but it tends to be a pretty short end stage kind of thing. So that's one option. But this is what's most common. And this is what we see because of all the chronic diseases that adults are living with at this point. So, you know, they're not in great health to begin with because of lung disease, because of some heart disease, because of diabetes, because of some kidney problems. And then they get sick, but they get better. And you notice that most of these times, so maybe this time they get sick, maybe they come to the hospital, and we fix them up, we give them antibiotics, we give them steroids to help their lungs get better, we give them high-dose Lasix or diuretics to help their heart failure exacerbation get better. And we patch them up, but you'll notice they don't quite get back to where they were before. Sometimes they might, but more commonly, when you get sick, it's tougher to bounce back. So each of these times you get sick and then bounce back. Sometimes the bounce back is slower, and it might require being in a nursing home for a month, doing some physical therapy to really build up that strength that was lost. But you still don't quite get back to where you were. And what's interesting is that any of these cases, some of them, if 100% feeling great is up here and they're down here, that's pretty close to death. So any of those events, that could be the one. That could be the last one, but you don't know. So how many of those will someone go through before they eventually die? I don't know. Sometimes the tail end of this curve gets a lot steeper, it gets a lot lower at the bottom, meaning someone could be really, really sick for quite a long time before they eventually die. But this is the most common manifestation of end of life in modern America because of all the chronic debilitating diseases that people are living with. This is not a failure, though. This is a result of modern medicine's success at extending people's lives, treating diseases. But this is what you get when you treat diseases, but you can't yet fix death. The final common pathway is still there. It's just a matter of timing, when and why. So, where people die. Pretty much any survey, if you ask people before they're sick where they want to die, people say, I want to die at home. Now, not everyone, because some people say, oh, I don't want to, that would be tough for my family to have to be there. But it's a minority of people who say, oh, I don't want to die at home. I want to die in a hospital. And no one says, I want to die in an ICU with a breathing tube in me. I want to have CPR before I die. No one's, but we don't die at home, by and large. Now, to be fair, it's very different to ask people these questions when they're feeling good and they're all kumbaya about their lives and their families. It's a very different story to ask them these questions when they're sick and it's like, okay, you're going to die now. What do we do? Fear of death, it turns out, is a very powerful motivating factor in people's lives. But most of us die in institutions. So even in 1950, up to 50% of people were dying in institutions. And in 2000, it was about 75% of people died, 50% in hospitals, 25% in nursing homes, only 25% at home. Hospice, I'll talk, I may not have the definition of hospice, but on this one I can tell you though. Raise your hand, who has some sense of what hospice is? Okay, most people. Okay. Briefly, hospice is a philosophy of care, meaning for people who can't be cured, we're going to focus on their comfort and quality of life and not focus on prolonging their life. It's a philosophy of care. And it's a payment mechanism for services. So it's a Medicare benefit, entitling patients and families to nursing care, social work support, medical equipment, pharmaceuticals, some aid support, and bereavement programs. The regulations are, how long, Carla? This long? This many pages? Highly administered by CMS, but hospice is has been the most effective tool for aligning people's desire to die at home with the reality of dying at home. So more and more people have been dying in hospice over the last 20, 30 years, when it's been 40 years since hospice really entered the popular culture of America. But to be fair, in hospice, the median length of stay in hospice does remain low, meaning that people tend to enroll in hospice only when they're pretty close to death. So I should say the median is pretty low, and the mean would be even lower. So in 1995, Carla may quibble with these numbers, and she would know better. It was 36 days, and many die within the first week of admission to hospice. I'm a palliative care physician, so I really like this stuff. Does anyone know, who knows what palliative care means? Okay. I should have had a definition to glorify ourselves, but I don't. Palliative care is not hospice. Palliative care is a medical specialty devoted to improving or relieving the symptoms and stress associated with a serious illness. It's a beautifully nebulous definition, which we love. We focus on improving the quality of life of patients and families who have serious illness. So not just at the very end of life, but certainly we take care of a lot of patients at the end of life. So palliative care and hospice programs have been great about helping people feel better near the end of their lives, physically, emotionally, spiritually. And there is some evidence that palliative care programs actually prolong life by attending closely to people's symptoms and making them feel as well as they can. But this is not really about me today. But one of the big interventions that hospice and palliative care addresses, and this is why I take a base from here, is in addition to skilled symptom management, it's about having conversations. And the idea being that the most important way to align goals, to align the treatments that we provide people with the goals that they want for their lives, such that people may be more likely to die at home if they want to, such that people may be more likely to avoid dying on a ventilator or in an ICU, such that people may be more likely to avoid the case we talked about, is just about having a type of conversation. That's really what palliative care is about, and that's really what advanced care planning, which we'll talk about now, is about. So this is about eliciting goals of care with patients and families. It's about addressing substantively their priorities in the time they have remaining. Now, we never know when we're going to die. Some of us know we might be a little closer than others. So all of us have certain priorities in the time we have remaining, right? I fully expect to live for the next 150 years. But I still have some priorities in that time. I'd like to be out of the hospital for as much as possible in those 150 years. So that concept in no way just applies to someone who's at the very end of their life. It could be someone who has a month, 4 weeks left to live, 3 months left to live, 2 years left to live. The importance is just the focus on that issue. A big part is navigating some of the inevitable trade-offs. I'm not facing right now trade-offs that I know about in my quest to live for the next 100 years. But if I was sicker and the future was looking a little clearer, there are certain things that I might feel strongly about, and I might have some tough choices to make. And this is a way of making sure that people get the care that aligns with their value and goals, and avoiding care that doesn't help them in that big picture way. So what to do, what to do? Here are some of the tools that I'm sure there's some degree of familiarity with in the room, but we'll focus a little bit more on specifically these tools and as they relate to all of us here. The living will, this is generally what people mean when they say advance directive. Advance directive, as a definition, the term advance directive would just mean some directive that says what you want to have happen near or at the end of your life. So it's quite nebulous, and that's fine. That's fine. So most people, when they say the term advance directive, they mean specifically the living will. And this is a very general outline of a person's wishes in the event that they're unable to speak for themselves. Now, the caveat here is in the event that they're unable to speak for themselves. That's the point. Let's repeat that to ourselves. In the event that they're unable to speak for themselves. Because if I can speak for myself, well then heck, I don't need any of this stuff. I'll just tell you what I want, right? Not totally, because there's value in the conversation, right? So there's value in talking about these things and thinking about these things. And the living will is a way you get stuff down on paper in case you can't speak for yourself. But I would say maybe even more importantly, it's a way of probing people to have conversations about what matters to them. So the goal I see of a living will is twofold. Get someone down on writing, but also make sure you're having a conversation about what you want. This is one of the accepted Montana advanced directives called My Choices. You can find it anywhere you care to Google, or maybe in some packets here. It's a this My Choices version is a pretty cut and dry type of thing. And on this next slide here, I'll do this one and I'll go back. My Choices, I crowded it all into one slide in a way just to show you that, okay, this is all that there really is on the My Choices living will. So check the boxes that express your wishes. I provide no directions at this time. Option 1, no choices. I direct my attending physician to withdraw or withhold treatment that merely prolongs the dying process. Okay, that's important. Somewhat nebulous is, we can parse that a little bit. It's kind of tough to sort out what that means. I further direct that, check all boxes that apply. Treatment be given to maintain my dignity, keep me comfortable, and relieve pain. That sounds nice. If I cannot drink, I do not want to receive fluids through a needle or catheter placed in my body unless for comfort. So this means don't give me fluids, if I can't drink, don't give me fluids through a tube or through an IV unless it's keep me comfortable. Don't just give me fluids to keep me alive. If I can't eat, I do not want a tube in my nose or my mouth or put in my stomach to give me food. So if I can't eat for myself, I can select that I don't want you to put in that stomach tube or have a tube going into my nose, into my stomach for a prolonged period of time if it's just to keep me alive. If I have a serious infection, I do not want antibiotics to prolong my life. But they could be used to treat a painful infection, so it could be directed towards comfort. So the My Choices advanced directive has a couple of options about treating infections, giving me artificial nutrition, giving me artificial hydration, and keeping me comfortable. And then it has the sort of the top level is don't just prolong the dying process. So this is, as you saw, this has a stamp of approval from Montana, Department of Justice. I think our governor signed something. Attorney General did things. It has an address in Helena, so that means it must be official. And it is. So this is an acceptable form of living will in the state of Montana. As you can see, the requirements for a living will are kind of, it doesn't have to go into a ton of detail. So there aren't any clear guidelines of what types of treatments must be addressed in a living will, which is fine, but it's not necessarily all that specific. It does require the signature of a patient and 2 witnesses. So patient and then 2 witnesses who cannot be healthcare providers involved in the care. They're not supposed to be family members. It can be, but it's not recommended. It does not need to be notarized. There's a space for a notary to do it, but doesn't need to be notarized. I think they say notarization is suggested or recommended. The 5 wishes is another more in-depth form that's actually a 12-page packet. And this goes through the process of completing a living will much more completely. So meaning it's, there's a narrative to it to help patients and families read through it. It's not just checking boxes. So the 5 wishes that patients and families address are, for one, designating a power of attorney, which we'll talk about in a second. Types of treatments that I do or do not want near the end of my life. For example, if I'm close to death, maybe if I'm in a coma with a low chance of recovery, if I have a permanent and severe brain injury, those types of things. Wish number 3 are the types of interventions I would want to promote my comfort. Wish number 4, how I want to be treated by others, such as nursing staff, such as healthcare providers. And wish number 5 is what I want my loved ones to know about me should I get to that time. So a couple of specific things and a couple of more softer, but no less important at the end of life types of things. And again, this is a great tool for having a conversation about these very important issues. Durable power of attorney for healthcare. This in other states goes by tons of different names. Healthcare agent, healthcare proxy are the 2 most common ones we also hear. In Montana, it's a very specific designation, and I should say that at the bottom here, most living wills have a section for the durable power of attorney for healthcare. Not all, but most do. For example, My Choices does, 5 Wishes does, so most do include that. So this is the person who makes decisions for you in case, in the event, and only the event, that you're unable to make decisions for yourself. Remember that. So it's not you ceding responsibility for your health care over to someone else. It's only if you can't make decisions for yourself. That could be because you're incapacitated, because you are in a coma, because you had a head injury, or maybe for some other reason you don't have capacity. So let's say you have a bad infection and you get delirious. And you're in La La Land, which people do. People go there sometimes. It's not as bad as it sounds. This is the person who can make decisions for you in that situation. And the most important concept here is the idea of substituted judgment. So I would never choose my mother to be my power of attorney for healthcare. And because of substituted judgment. The idea of substituted judgment, it's not what the healthcare agent wants from me. It's not what my mom wants from me. It's what my mom knows I would want for myself if I could make the decision myself. So I would never choose my mother because she'd never be able to say that it's not what she wants. She would do everything she could to keep me alive, because good God, like no one wants to lose their son. I'm not saying you shouldn't choose your mother, but don't choose my mother, I guess. But this is so important, and it can't be overstated. And we bump into this all the time. If you're choosing someone to be your power of attorney for healthcare, you need to choose someone who you know can make the decisions that you would want, not what they want for you. And it's the other very important thing is that how does that person know what you would want? Well, only if you tell them. So this necessitates having a conversation. Now, you could argue that if it's your spouse who knows you so well, that maybe they'd be able to figure out based on what they know of you or how you've lived your life, what you would want in certain situations. And I would say, baloney. It requires having a conversation. It's easy to leave out the conversation, I'll say that. It's much easier to say, hey, will you be my healthcare agent? Oh, sure, no problem, great, love to. It's much easier than actually talking about what that means or talking really about, so when it happens, when I get the brain injury and when I'm lying in the coma in the ICU, I want this, I don't want that, is that cool? Here is the independent Montana DPOA for healthcare. It's a lot of words because lawyers wrote it. Sorry. But it really says, I am me, I want this person to represent me, and here are some witnesses. That's basically what it says. And it only takes effect if that person is unable to make decisions for themselves. Again, it can be notarized, doesn't need to be notarized. I don't know why that should ever be optional. It seems a little... Thank you, whoever said that. This is one of the most beautiful things that Montana has and a lot of other states have. A central depository, thank you, Linda. A central repository for keeping these things in a central place such that anyone can access them. Now this is relevant if someone comes into the ER, we don't know why they're there. They have all sorts of things going on. We don't know how to treat them. Maybe they have life-threatening illnesses. We don't know how to treat them. If their information, their living will, maybe their DPOA for healthcare, maybe a poll star, in this registry, we can log on to the interwebs, we can access their information and see what their choices are. Amazing, amazing, amazing. To get your advance directive to the registry, it's slightly cumbersome. We're all hopeful that in the next few years it'll get a little simpler. You have to do the thing first, that makes sense. And the patient themselves has to do this. You can't do this on behalf of the patient. The patient has to be involved in it. Complete the end-of-life consumer registration agreement. So that's saying I give permission for this, yada, yada, yada. Mail the forms to Helena. Wait a couple of weeks. Then you get back verification. You get a little wallet card that says my advance directive is in the registry. And you get a couple little stickers that could go like on the back of your driver's license that say, hey, check out the registry, you'll find stuff about me. So great. So a bunch of ways of alerting people who may, EMS providers, physicians and facilities, it might provide things for them. To change an advance directive, you have to do it all again, which is okay. But people do change their mind, and that's good. It's good to have more conversations about it and readjust things. Pulsed is physician orders for life-sustaining treatment. I'm sorry? Provider, yeah, thank you. Oh, I'm sorry that these are in black. Well, just to make sure you're really paying attention now, apparently. So this is a medical order. So these are medical orders. The same way a provider might write a prescription for you, and if someone else tries to write a prescription for you, they'll go to jail, that kind of thing. This is medical orders that medical providers write. So it carries the weight of a prescription, the weight of an order that only a provider can do. And it's a portable document that I think I have a picture. Oh gosh. There it is. It's a portable document that people carry with them. This is not the color, of course. It turns out it can be any color. It's, I don't know if there's one in the packet. That may or may not be. Who's seen a Post? Has everyone seen a Post? Okay. It's yellowish green. It's beautiful. Not the most beautiful color, but and it has a couple of. It's really a one-page document and some stuff on the back. A Post allows individuals to choose medical treatments they want to receive and identify those they do not want in the event they're unable to speak for themselves. Now, unlike a living will, which is general guidelines for how someone will want to be treated, these are specific, actionable items that medical teams must follow. So it provides directions for us. I'm sorry, I don't know why these are so hard to see. So these are good for people who have really serious illnesses and might not survive it if they were to get really, really sick, and might not want to be put through the trauma of attempting to survive something that they're quite unlikely to survive. That's the idea. People who have serious health problems, who are very medically frail. As providers, when we're thinking about whether someone needs a Post, we think to ourselves, would I be surprised if this patient died in the next year? Oh gosh, I'd be surprised if I died in the next year, which is why I don't have one. But we see patients every day who we wouldn't be surprised if they died in the next year. And when that happens, then we think about, okay, maybe we should have this conversation specifically. So there's one form for the whole state. This is an official thing. There used to be an old Comfort One form, if people are familiar with that. Post has since replaced the Comfort One. Old Comfort Ones are still honored, but in case you're wondering how that fits in, Post is the new Comfort One. And an important thing here is this provides immunity from civil or criminal liability. So if I'm a paramedic and I'm rushing to a scene going to save someone's life and they're in cardiac arrest, and the law says that I need to try to save them unless there's a Post there saying don't try to save me, I will not get sued. Not at all. Great question. Those are general guidelines. There are not specific actionable items. This is a doctor saying don't do or don't do something. So it's a great question though. Again, this is not just checking forms. It implies a conversation. It really does, and it requires a conversation. So who can complete this? Any providers can complete it. Anyone in healthcare can go through the Post form. Only medical providers can sign it because it is medical orders. Again, I'm so sorry that we can't see these. Again, these are medical orders, not just non-specific patient wishes. Here's what it looks like. I'll just take you through the sections really quickly. The name up top, physician authorization on the bottom, and there are a couple sections here which I'll go through. Oh, yeah. Oh, great. Oh, great. Okay. Oh, yes. So we'll go by that. Well, it's not. This is not the current one. This is the current one. Yeah, the other one was old. I'm sorry, that came from the. So the top says, if my heart stops, either do CPR or don't do CPR. That's pretty cut and dry. All right. And the indications for doing CPR are pretty clear in the medical literature. It's not something that's done willy-nilly. So if someone has a very low chance of surviving CPR, then or recovering after CPR, that's a situation where someone might say, if I die, let me go. If my heart stops, let me go. That's it. Section B is about treatment options. And this is a little bit more broad, but it gives some outlines. An option here says comfort measures only. So this means this is that hospice model of care. Just keep me comfortable. I don't want to do anything that prolongs my life. My focus is explicitly on comfort. Keep me at home if at all possible or wherever I am, Bring me to the hospital only if you have to keep me comfortable. That's what that first section says. The second section says limited additional interventions. So in addition to keep me comfortable, it says, relieve my pain and suffering through all kinds of medications and other measures, but treat things that you can that are not too challenging or aggressive or invasive. It says use oxygen, suction, and other treatment and manual treatment of airway obstruction as needed for comfort. Oh wait, I'm sorry, that's the one. Use treatments to help keep me going, keep me alive, but do not use aggressive ICU level measures such as intubation. Don't put a breathing tube down my throat if it looks like I need that, if I'll die without it. I don't want that. Don't use other advanced airway interventions. You might use some of the softer airway stuff. We don't have to parse all the specific details, but some people who have sleep apnea know that there are these machines that can blow air into your face, and sometimes people sleep with that. And sometimes that can save lives or prolong lives or get people back. Saying maybe do that, but don't put a tube down my throat. I don't want to be in a breathing machine. Try to avoid having me in the ICU, is that sort of idea. It's like maybe some of the general medical stuff, but if I'm really sick and I need to go to the ICU, then let's really think twice about that, because that doesn't really align with what I want. And then the third option is full treatment. Do whatever you can. Do whatever you got to do. Section C is about tube feedings, and it's either don't give me artificial nutrition by tube. Don't put a tube in my nose to feed me when I can't eat myself. Don't put a tube in my stomach. Or maybe let's do a trial of one. Maybe put a tube in my nose and my stomach to give me some food for a couple of days, a couple of weeks to see if I get better. Or yeah, go on. Let's put tubes everywhere. That's the third option. And then the last section is about who this was discussed with. And then the provider signs it, the patient name, patient signs it. So this is, anyone can fill it out, provider must sign it. I went through all these. So again, post can go to the end-of-life registry, but the actual copy of the post stays with the patient, and that's what's most important. And this I didn't maybe address. When is this document relevant? Post is only relevant when the patient can't speak for themselves. Now, at the same time, it implies general wishes, so often it's an outline of the general wishes for their care. But if the person can tell you what they want, then they'll tell you what they want. So if a person has a post, and the post says DNR, or the post says don't do something, but the patient says, if the patient is of sound mind and says do this for me, well then you do it for them, right? Because it only takes effect if they can't speak for themselves. So the EMS providers, they all know this, and they struggle with it, and maybe some of you have seen cases been challenging. I'll skip over this. Can post be changed? Yes, at any point. As long as someone has capacity to make the decisions, they can change their post. You could do a new one every day. Just go back and forth, back and forth, back and forth. You can send them to the registry every day. Nothing is binding here. And the patient keeps the post. That's what's really important. If they're in a facility, it stays with them or as close to them as possible. Does post work? Yes, 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 yes. This is the last, and then we'll open it to questions in just a minute. Does post work? This was a study out of Oregon that they reviewed about 58,000 deaths, and they noticed, I'll just skip to it, the options of full treatment, limited interventions, and comfort measures. And for patients who selected comfort measures on their post, the overwhelming majority of them died outside of the hospital. So that's pretty good, that patients are saying, I just want to be kept comfortable. I don't want to come back to the hospital unless I absolutely have to. And it works. Good case. We saw bad case before. We'll sum it up with good case. Similarly aged guy, previously healthy, found down in his apartment after he didn't show up to work for a couple of days. severe traumatic brain injury. He was unresponsive. Intubated in the ICU. His daughter was called the day he came in. He didn't have a pulse or anything, so the EMS folks, they intubated him, they brought him to the ICU, put him, he was up there. His daughter flew in from St. Louis, and she brought a power of attorney for healthcare form with her because she had one that he had signed designating her the power of attorney. She knew where the copy of his living will was at his house, so she went to his house to get it. And she could basically recite verbatim the conversations that they'd had about the types of conversations they'd had about what his wishes would be in a situation like this. There was absolutely no doubt among any of the family members about his wishes. Family, the next day, family came in from around the country. They were devastated that he died, but they knew they were doing what he wanted them to do. So life support was withdrawn. Care was transitioned completely over to making sure he was comfortable, and he died within 6 or 12 hours. Family at his side, appropriately devastated, but very joyful that they had done right by him. Very different from the first case, and I think more in line with how all of us imagine the end of our lives might go. How to promote these things, I won't go into this right now, but Medicare now pays providers to have these conversations as of January of this year. Health systems are promoting this. Providence has a big initiative, started among employees, but now it's out to the public. There are a lot of community-based initiatives as well to promote these conversations and completion of these. Missoula Aging Services does a lot of work with this. Concept of death cafes, have any of you heard of those? It's people coming together at coffee shops to just talk about this stuff. Pretty cool. Maybe one of the best resources for the lawyers is the ABA Commission on Law and Aging here, which some of you may be familiar with. Or if you Google the ABA Toolkit for Healthcare Advanced Planning, there's some great resources there. I went way over my time. I didn't leave my 5 to 10. Questions? Concerns? Bright ideas? Great question, and I'm going to ask Linda Bierbach, our resident expert on all issues advanced care planning, who's nodding her head yes, to just fill in the gaps.
Thank you. I'm always in contact with Joan Ely, who is the administrator of the End of Life Registry in Helena. And what the answer to your question is that they have a 24/7 phone line that's available that can be called, and they will access that advance directive for who's ever asking for it. But again, families are highly encouraged to know the access information so that that also can be shared with the outside of state of Montana staff looking for that document. And what we also do in the state of Montana, every organization has an opportunity, and did when it was initiated in 2005, to have an access code so that we can actually go in and look it up without specific patient identifying information. We only need 2 specifications, first and last name, or last name and date of birth. So we really encourage people to understand that it's accessible, not only in the country, but around the world.
Thank you.
Okay.
But they would need to know to call. And how would the phone know exactly how would they know to call?
Yes. Yes,
Yeah.
and again, when we educate people about the use of the consumer registry form, we inform them that it's very important that they carry their identification card with them, and that identification card carries that information. Because there are very few states that actually have advanced directive registries. We're one of them, maybe a handful that do. There are national registries available, and I'm not that well versed on that, but again, we're a handful that has one.
It seems to me, I'm a lawyer, and it seems to me that when you designate somebody having your power of attorney, and you also do an advance directive, you have a question about what takes priority. In other words, and I usually have this conversation with my clients. I usually say, look at, you can give the person that has the power of attorney authority over your advance directive to make an independent decision on what they think would be best for you. That puts the burden on the person having the power of attorney. Or you can say to them, no, you have my power of attorney, but you must follow the directive that I set up. This then takes that responsibility away from the person for making that. That conversation that I have with my clients is really a good one because, in my opinion, because it really, they make a decision about where they want, what they're comfortable with, and the person that's getting the power of attorney really knows what their responsibility is. So that's something that I do. I don't know whether, otherwise I think there's an ambiguity.
There is an inherent ambiguity in a living will because they're general concepts that there's, of course, it's impossible for a living will to outline every possible scenario. And very seldom, if never, does a patient actually fit neatly into some of the little boxes that were checked on a living will or an advance directive. So there is an inherent ambiguity. The living will outlines general wishes and general wishes. So, but I think that idea is a very good one. That certainly the power of attorney, fundamentally, their job in a way is to interpret the living will if it's there. If there's a conversation I would think that the living will would outline the general guidelines. So if the power of attorney was saying, no, they actually really didn't want that, we'd have a lot of anxiety over that and we want to dig a lot deeper. But I think that conversation is a very useful one to try to help with your clients to parse that out a little bit.
Another question I have is, in those documents, because of HIPAA, are there certain things that need to be given to the person having the power of attorney so that the doctors and hospitals know that they have the kind of authority and if it's not there, then do they really have that authority? I'm wondering what hospitals and doctors want us to do, require us to do.
Yeah. I've never dealt with, I'm not aware, there is not a rigid identification process or like they show your secret card or something or say the secret password to prove that you actually are the person that has been designated or that you're actually the one who has this role. So I think from a medical perspective, there are not explicit requirements to ensure that. I think, are we getting ourselves into trouble when we say that we generally trust what we're told and how that works? So I don't think there's specific recommendations that you need to counsel your clients on about how to sort of attest to the fact that you are the actual power of attorney. If it's in a document, and if it's in an official document, then I think you can say that it's trustworthy and will be accepted by providers throughout the state. Please.
And I'm concerned on its face, it also could be read to cover a treatable condition.
Mm-hmm.
For instance, I might check some of the zone
Mm-hmm.
and send you to life-saving treatment. But let's say I have a bowel obstruction.
Uh-huh.
And for some reason, yes, I want to treat that bowel obstruction.
Uh-huh.
If I comfort measures only says comfort measures only,
Uh-huh.
I wouldn't treat the bowel.
Right. It is a possibility. Comfort measures only means you're focused only on comfort. So if you have something that's going to kill you, then you will not survive that. So that's why comfort measures only is only for people who are right near the end of their life.
But let's say I'm near the end of my life,
Uh-huh.
and I get a bowel obstruction.
Uh-huh.
This form says they won't treat the bowel obstruction.
They'll treat it such that you will be comfortable. So they wouldn't inherently do the things that they would normally do to necessarily treat a bowel obstruction. They wouldn't put an NG tube down into your stomach unless it was to promote comfort. So comfort measures only means I'm nearing the end of my life. I don't know what's going to kill me. Maybe it's going to be pneumonia. Maybe it'll be a bowel obstruction. And I'm accepting that and saying, keep me comfortable despite that process. Now, if I say I'm near the end of my life, and I'm ready to die, unless it's for this or this or this, then comfort measures only isn't for me. If that makes sense. Okay. Yeah. Post is signed by a physician, so they're medical orders. So so that would trump because a post form was a discussion between a patient and a medical provider. So post would trump that. Now, if the power of attorney said, I know they did the pulse, but just 2 days ago after that, he was saying, I'm not so sure about this. Oh gosh, I was having second thoughts. Now everyone would take that into consideration, certainly, and there would be a dialogue there. So it's not just because you have a pulse. So even though that trumps, I think every treatment team, it's open to ambiguity. So if there's a compelling reason to say that the power of attorney said, we had this conversation yesterday, or very compelling reason why that was not necessarily valid anymore, then that would be taken into account. But yeah, if you're at home and a paramedic comes to your house and there's a pulse on the fridge that says, allow me to die, but the power of attorney is saying, no, yesterday we had this conversation, then I guarantee you that will get dicey, and there's not a clear answer for that because that's a pretty active, tough situation. So paramedics by law have to follow that pulse. So what I would say is if you know that someone is having second thoughts about a pulse, rip up the pulse. It's a document, but it can be changed or ripped up at any time.
I wonder if you would say something about what's wrong with holding fluids, and I asked questions because I'm a little bit curious. Family members often do not understand what that means to my person. Comfortable with that fluid.
Yeah, that's one of the biggest, that's a challenge for all of us every day. So this talks about the importance of the conversation. Now, and I will say that on advanced directives, it can be a pretty in-depth conversation. Without getting too much in the medical stuff, people have been dying for a long time. And that was a wise statement if there ever was one. But the point, which is to say that the human body knows how to die in a way. So death is a not inherently painful process. So when I'm talking to patients and families, we talk about how as the body is shutting down, people don't need to drink as much and their thirst mechanism goes down because they don't need the fluid anymore because they're near the end of their life. So giving extra fluids can actually do more harm than good in those situations because the body doesn't want it, the body doesn't need it. So it's sort of this concept of just sort of following the body's natural rhythms for the end of life. But it's a tough conversation that we have day in and day out with patients and families. I know we have very limited time. What I might do now is just finish some of these other questions in the back. Does that make sense? After? How about we'll do one more, I guess.
One more.
Is there a time limit on these various documents? Like, does the durable power of attorney have an expiration date? Does the advance directive have an expiration date?
That's a great question. None that I'm aware of. Does anyone have any? Until changed.
They can.
They can. I'm sorry, Aaron?
They can.
Yeah, they can.
If it's written
You're right.
in, if you can make it whatever time frame you want.
You lawyers do whatever you want to do with that. Okay, thank you all.
Let's end there. Thanks, Dr. Jons.